So we are going to be going over this right here. This is the 2014 perioperative cardiovascular evaluation and management of patients undergoing non-cardiac surgery. This was released in 2014. A lot of the guidelines that are out there and up to date, and a lot of other places kind of go off of that. It's pretty extensive. It's pretty broad for a lot of things. We are going to go over a very simplified version, quick and dirty and simple. I've kind of broken it down into this really easy format. So the very first thing you want to do is, if it is an emergent surgery, meaning you have to do something within 6 hours, you're probably going to get cardiology involved and the surgeon, and they're going to hash it out and figure out what they need to do. After that, if it's non-emergent and you have some time to work them up, the very first thing you're going to do is determine if there's any issues going on with the heart that you need to fix first before you can do an actual assessment to see if they can have surgery. So for the most part, is there an issue with the valve, pacemaker? Is there an issue with the do they have pulmonary hypertension? Should you get an EKG? What do you do about heart failure, stress tests? What about if they had balloon angioplasty or had a drug-eluting stent or bare metal stent? What if they're on dual antiplatelet therapy from a stent placement? And so you can kind of see the recommendations there. I'm not going to go over all those, but you want to follow those. And there's a lot more in detail stuff in the actual article. It's free on the American Heart Association webpage. So once you have that all taken care of, then you can move on to assessment. So there's a couple different assessments. There's the Lee score. There's a whole bunch of others. The two that are in that article is the RCRI and the NSQIP. I'm going to do the NSQIP. It's the one I like a little bit better. There's risks. There's different things why you would choose one or the other. But we're going to go over the NSQIP. So let's say I got a patient coming in. Like I said, everything here is good. Let's go over to the NSQIP. All right, so this is on the American College of Surgeons webpage. Just type in NSQIP and it'll pull right up in Google. Let them know that you're not a robot. And the first thing it's going to do, there's going to be a DPT code here, and you have to put in what procedure they're getting. So actually I'll put in, let's do cholecystectomy. We'll do appendectomy. So we'll do an appendectomy. Let's say it's laparoscopic. So the DPT code is 44970. You can Google that if you want to. But now, since every surgery, there's low risk, there's high risk, that's in there. We're ready to go. Vascular surgery, for example, very high risk. And we'll say that there's no other options. They got to get that surgery. Let's say our patient is 55 years old, female, they're independent, great. Emergency case, no. Let's just say they have some mild systemic disease. They're not on steroids. They don't have ascites. Let's say we meet some SIRS criteria, but they're not super septic. They're not on a ventilator. They don't have cancer. Let's go ahead and say they're on some oral diabetic medication and some blood pressure issues. No heart issues. They have no dyspnea. Let's say she's a smoker with COPD, not on dialysis, no renal failure, and let's say that she's 5'2", so we'll do 62 inches, and let's say she weighs 135 pounds. So you enter in their basic information. You got to know a little bit about them, what medications you're on, stuff like that, and then you can go ahead and you're going to continue. Once again, you let them know that you're not a robot, and then it's going to go ahead and print a bunch of stuff off here. So the main one we're worried about is cardiac complications. Or MACE, major adverse cardiovascular events. If it's greater than 0.1, in this case it's 0.3, that's going to warrant a little bit further evaluation. We're going to talk about that in a second, but look at all the other things we have in here. serious complications, UTI, surgical site infection. You know, she has a 6.4% chance of readmission. When it's in the red, that's above risk for their age. If it's in the green, it's below risk for the age. Now, if you go a little bit over, if I would have put in 65, 70, it would have given me the option of determining if they're going to need some type of ambulatory assistance device, or the chance that they may have to get some rehab afterwards, and that would be just below this, and it'd give you some more information. This is what you're going to pass off to the surgeon, and anesthesia. This is what you're going to put your note in. The main one is that cardiac complication, but there are other things on here which are also important. But the best thing is you hit continue. You can go ahead and email it. You can print it off and put it in the file, whatever you want to do. Now in this case, it was only a 0.3% chance of major adverse cardiac event. Let's say it was over 1%. And so if I go right here, so if it's low risk and the patient and surgeon agree with those risks, you proceed to surgery. If it's greater than 1 risk of major adverse cardiac events, or MAKE, where you'd go down to calculate the MET. So metabolic equivalence of task is how much energy or expenditure are you doing with folding your laundry or walking or stuff like that. Now, they do recommend using the DASI score, and that's on, it's right here on MedCalc, the Duke Activity Status Index, and basically it has the amount of metabolic equivalents that are on each one. So in this case, the patient can do all of them, and they have basically 10 METs. That's phenomenal. Anything over 4 is great. So let's say we do a couple of these here, and we take some off. All of a sudden we're down to 5.62, still okay. We take even more off. They can't even climb. So now they're down to, they can walk around indoors, they can take care of themselves, they can walk a block. Now we're at 3.63 METs. If they're above 4, you proceed to surgery. If they're below 4, you're looking at a cardiac stress test if they would agree to go into the cath lab, and if they would agree to possible stents or CABG if possible. And this is essentially it. This is all you need to do. And that is how you do the American Heart Association perioperative risk assessment. Make sure you're communicating with the surgeon, make sure you're communicating with anesthesia, make sure you're writing a good note about it, giving all the percentages of everything that's going on, and then make sure that you're talking with the patient and making them aware of the risks. If you send everything to the surgeon, they're going to go over those risks again, but that is essentially all you need to do. If there's any questions, you run into any roadblocks, you're sending them to cardiology, or you're at least calling cardiology and talking with them, and that is it.